trans men. I have few more patients like this, but trans men who are in different phases of transition. We have a trans masculine association, Orinam, and the mari nariya organizations are there to help them with the transition process, legal process, medical documentation, etc., etc. But this, once they go on hormones, it's sort of very, you would probably not, recognize that this person is actually a female to male, because legally everything will be changed, their passport will be changed, their official documents will be changed, the new gender will be a male. That's whatever gender they want to call them, right? And this is how they look. This is the organization with whom I sort of also work with. So we'll go to a second case and then we'll talk about the medical problems. So I have only a few more minutes. This is a 22-year-old male, internship in a private medical college. So I have about 3 or 4 doctors who are transitioning at different phases of transition. This person is in a private medical college. We call, the correct terminology is not even transgender. Transgender nu kuda sollakudadu. The current terminology is gender incongruent. That is the medical approved terminology that we use, gender incongruent. He identifies as a she. So she is what we have to call her as she right now. She wants hormone transition but wants a slow transition. The beauty of hormone is நாங்க எப்படி கொடுக்கறோமோ transition அந்த மாதிரி கொண்டு வர முடியும். So basically there is a protocol in place, but we tailor the therapy according to what the gender incongruent person wants. So small dose வேணும்னா small dose, full transition, again we will monitor them, but inga வந்து since this person wants to finish his internship, அதுக்கப்புறம் legal process start பண்றதுனால we wanted a slow transition, which we'll do, and normal pubertal development, no other issue. So bisexual but no stable partner, occasional smoking history, and he also smokes marijuana. She also smokes marijuana. So this is a transition that we are talking from a male to female, which we call as a trans women or trans female, right? So first clinical case order exact opposite in the clinical case situation. And here we give first, put them on androgen blocker, இருக்கிற testosterone suppress பண்ணிட்டு, we will either do it with aldactone, which is the spironolactone, or GnRH agonist, or we will put them on estrogen, right? Once they go for a transition, after 2-3 years, this is how they look. You cannot, with the proper protocol in place, there are Malayalamla வந்து, there are actors who are trans women who are on gender affirming therapy. So on the mari, there are a lot of well known prominent people who are on hormone therapy. Once they are on hormone therapy, you cannot really tell the difference. And of course they will go for surgeries, cosmetic procedure, dermatology. We need dermatologist help for laser therapy, ENT physicians help for voice modulation. நிறைய protocols இருக்கு, but if they do this 2-3 years with regular follow up and everything, ஒரு 4 to 5 yearsல the transition will be very normal, absolutely normal, right? This is what we modulate with hormones, with a multidisciplinary approach. We have a psychiatrist in place, we have a dermatologist, we have gynecologist. We get the help of everyone to do this, kind of help us with this process. So what is gender affirmation? Now, first we need to understand, some of them will want only identity change. They'll come to us and say, "Enna ipdi koopudunga podum, I don't want hormones," right? Hormones is not mandatory, right? Ellarkume hormones kodukka maatom. If somebody wants hormones, we'll give them. Some people will just come and say, "Please call me so and so," right? We'll take the questions at the end, ma'am. This is not a genetic disorder. Ma'am is asking if this is a genetic. These are all normal people like you and me without any medical problems. Absolutely normal. We are not talking about DST. Disorder of sexual development is different. That is a complete different basket we are talking about, where you have 5-alpha reductase deficiency, androgen insensitivity syndrome. We are not talking about this. These are normal karyotype XYXX people wanting to transition without any underlying genetic problems or medical problem or psychiatric illness. எதுவுமே இருக்காது. They just want to undergo. This is how they identify, and they want help of endocrinologists and other department people to help them transition. So some of them would want only hormone treatment. Adle, they will tell us how much they want to transition, so we just need to listen. Basically, what I've learned treating gender incongruent person is that you need to be very empathetic. That's one thing that I've really learned, to hear them out, listen to them, and treat accordingly. And even in surgery, there are a lot of surgical options available. We get the help of a urologist, gynecologist, and plastic surgeon. This is again not mandatory. Some of them will go for surgery, some of them will not have surgery. But we will just document in the notes saying that yaarku enna mari procedure pannirukanga, so that when we do for follow up, or when they grow old, when I grow old with my patients, I will know that this patient has not undergone surgery. I need to keep in place prostate irka, cervix irka, lipidemia, fatty liver, PCOD as a marker for future cardiovascular disease, etc. But ide testosterone, tomorrow you will have a Jugalbandi with Dr. Sriram Mahadevan and Suresh Damodaran, where they will talk about hypogonadism in male. Ide lack of testosterone in male causes the exact same insulin resistance, diabetes, central obesity. So how does this hormone behave in male and female? Similarly, when we put them on testosterone, there is some evidence of already, if we have family history of diabetes and features of insulin resistance, there can be a higher risk of metabolic derangements, which can happen, right? So from the hormonal perspective, yes, there can be, from the therapy that we give in terms of estrogen and testosterone, there can be problems. And we, of course, genetic predisposition is always there for the Southeast or South Asian phenotype, as Dr. Mohan sir pointed out. In terms of dietary patterns, in terms of behavioral influence, most of them don't have, I have different social, people from different social classes. But if you look at that dietary pattern, a lot of people homeless and stuff, or proper, nama solra mari carbohydrates korenga, protein edutukonga, fiber edutukonga, may be very challenging for them. They eat biryanis that are available, it's very difficult to also work around that social situation of how much they can afford for food. The good, healthy food is always expensive, right? So that also have to take into account. Irukkrada veche we should really do that. At least you can start saying that late night sapradinga, velila vaangi sapradinga. Whatever little bit that you can do from your experience, you can educate them. And physical activity levels, again, that can be a challenge. And majority of the problem comes here, substance abuse. Romba common. Smoking, alcohol, weed, ganja, everything is very common. So we usually document them every single time when I see them. I usually see them first 3 months in the first 1 year, and then every 6 months for the next few years, and then a yearly after that. Every single time I see them, I usually tell them, please don't smoke, no alcohol, no substance abuse, because this is something that is very important, and we know the impact of alcohol and smoking with the risk of diabetes and the metabolic syndrome, which I'm not going to talk about that because that is not something that I'm going to. In terms of intersectional consideration, again, once they start the hormones, a lot of times when we start female to male on testosterone, they bulk up, nalla muscle varum, they look more masculine, they feel, male, their orientation changes, how they, feel, this is what they have told me. Of course, I have not experienced any of these things, but this is, their eating habits change. They tend to smoke because they think smoking panna and the gettin nanipanga. So, all those things, again, can be a challenge. And oral estrogen, again, has shown to have some lipid abnormalities. I'm done. This is my last slide. And again, substance abuse we talked about. So in terms of cardiovascular data, there is no clear-cut evidence for it, but we will screen them. We will make sure the metabolic derangements are taken care. And when they do come for that, please, sort of echo on the same thing so that we address the same thing multiple times. We also worry about thromboembolism in estrogen therapy. So we always go low, and we also prefer estradiol valerate, the preparation of estrogen that has the lowest thromboembolic risk, and we preferably use spironolactone more than cyproterone acetate. So these are the hormone things that we will take care from our side. In terms, I'll go with this. This is my last slide. So in terms of intervention, lifestyle, medical treatment, nothing different. We treat diabetic patients at almost same time, and little bit of cognition to their social, environmental factors, societal things and everything. And of course, ongoing mental health support is very important. They need to regularly follow up with psychiatrist or psychologist whom they are following for regular mental health support. This is the group. We do have periodic meetings with the transgender community. We either do this offline or online. We we'll try to tell them that you need to come for follow-up, cholesterol check pananum, blood pressure check pananum, you need to exercise, no smoking, no alcohol, screen yourself for metabolic disorders, see a physician close by, treat your metabolic disorders, keep your weight under control. So whatever we discussed here today, we will also tell them in a way that they can understand, so that this sort of, and they will pass it on to their friend, and the Madri, we have organizations like this. In the Madri, we do conduct meetings in trans-masculine associations as well. So with this, I finish. These are the future research that we can do in terms of transgender. We can publish a lot of data on this. Unfortunately, I don't have the time to do it. With this, I thank the audience and the organizers for this opportunity. Thank you, sir. Thank you for giving me this opportunity to do this, because I've been wanting to do this for a long time. Thank you.